So I was born in Oldham, I grew up in Bury, and I now live in the North East. So it's always great to be back speaking in Manchester. So I'm going to be talking about VR treatment in relationship to anxiety and our evidence base for people, for autistic people and people with learning disabilities. And I'm going to talk about a research journey through to clinical provision. I'm going to do the first half of our talk, and it's going to be over to Billy. I do this slide in relationship to registers of interest because I'm a clinical academic. I'm employed by a university. I work in the NHS, and I'm the academic founder of XR Therapeutics. I have some shares. I'm a director. I sit on the board, and it's important you have that context before I speak. I'm going to talk a bit about the design and evaluation of a novel virtual reality environment for treating anxiety for people with autism, and a journey from an idea through to clinical service and delivery, some evidence from observational studies of pilot RCT, NHS provision, and the decision to create a company to take this forward before handing over to Billy. Many of you are familiar with anxiety for autistic people. Anxiety is really common. It's at least 50% of young people and adults, and people have multiple anxiety conditions concurrently, and situation-specific anxiety, phobia, extremely common for autistic people. And these fears and phobias experience can be simple, and or they can be unusual and atypical. Some of these anxiety situations relate to sensory sensitivities, but there's no question that there is a real impact on people's everyday lives. I'm not going to read the examples out. We also know that CBT, cognitive behaviour therapy, is recommended by NICE for autistic people, children and adults, in terms of adjusted group cognitive behaviour therapy, but also individual CBT. But when we were thinking about our work, initially we found that really there was a massive challenge in relationship to what usual care was. It was extremely variable what people would receive in relationship to the treatment of phobia. And most people were not receiving anything rather than, or even 8 to 12 sessions of CBT in relationship to anxiety. Long waiting lists, getting longer, and bear in mind this was the very beginning of our journey in 2010, 2011, rather than how things are nowadays. So we created a manualized intervention, which was an immersive technology using computer-generated images projected onto a curved screen or walls of a room. So you can see here an XR Therapeutics image. And participants weren't wearing headsets or goggles for this research. They were sitting in a room with a therapist alongside them, and then navigating through a scene that was personalised to their specific anxiety situation using a handheld computer. So Helen McConaughey and I, Helen McConaughey, Professor of Clinical Psychology now, Emerita in Newcastle, designed this initial treatment. As I've said, a therapist remaining throughout a treatment session, so this is cognitive behaviour therapy, exposure, individualised scenes for a person, I'll talk a bit about that shortly, incorporating exposure hierarchy for that feared stimulus, and brief sessions. So this is just on one day, 2 sessions, space in between them, and then coming back a week or so later for another 2 sessions with a space in between them, and then going on to a real-world evaluation of how they've got on after that. So the therapist then providing guidance all the way through, and then thinking, well, actually, how are you going to manage in the real world in relationship to this? And that was the limit to what we did. And we were trying to create something brief to address some of the challenges that have already been referred to in relationship to capacity as we go forward. So I'm going to show you a few common sets of scenes. Billy's going to show you video later, so I'm not going to dwell on these. But these are the sorts of things that people find really, really difficult, that have an everyday challenge for them and affects their quality of life. I'm not going to go over our whole research evidence in relationship to each of these papers because it would just take too long, but 4 published, peer-reviewed published research studies in relationship to this area, 3 small observational studies, and then a pilot randomised RCT, not a fully powered effectiveness and cost effectiveness RCT, but a pilot feasibility study. And if you look at that in the in the context of the evidence. Back in when we were doing this in 2016, 2017, that was a huge amount of evidence that we had. We then found examples like this one. So pigeon phobia with this 11-year-old boy who had such a severe pigeon phobia that he didn't go to school because the pigeons would land in the playground and he could see them and was always looking out the window for them, and therefore he stayed at home. So not only did he not go to the shopping centre with his parents, he couldn't get into school and complete his education. So he had increasing challenge through VR setting, one pigeon coming in, flapping closer to him, multiple pigeons coming in at the end, and he was skilled up to learn how to manage that in a VR setting rather than a real world setting, which would never have got him into in a million years. And here's his quote: "I still have fear of pigeons." Insightful, isn't it? But it doesn't control me in the same way. A whole list here of the sorts of specific phobias that we treated in the RCT. We treated we had a treatment group and a control group, and we treated the control group second. So effectively it was a delayed control group study, for those of you familiar with that sort of methodology. But you can see here some things that are really common: balloons, insects, less common things like mascots, bananas. We then measured outputs in relationship to real-life change, 9 months from baseline. We used something called target behaviour rating, which I'm not going to go into in detail. If you want to ask me about it later, please do. For the initial treatment group, 6 out of 16 showed definite improvement, 1 out of 16 was worse. For the control groups, I didn't receive anything. None of those 16 showed any improvement. 5 out of the 16 were worse. It's an effect size of about 1. When we then treated the control group, remember that none of them had improved initially, 9 out of the 16 then showed definite improvement subsequently. So total definite improvement, about 15 out of 31 people. We conducted a children's development study before that. We conducted an adult development study at the same time as we were doing the RCT, showing some evidence of effect with adults as well. We then, if you put all of those data together, it showed a real-life improvement for about 50% of the participants, around 53 people when the research was undertaken with. And really interestingly, the NHS and the university then took the decision that they wanted to create a service on the back of that evidence, because of course we know about the evidence for CBT. We don't need loads more evidence. Well, you could make an argument that you do need more evidence for cognitive behaviour therapy in certain groups of people, but actually this was a way of delivering cognitive behaviour therapy more effectively with the adjustments that people need to make it useful for them. And the Trust then took this through research and development, innovation group decision making, medical director sign-off, board support, said if you have an evaluation plan in place, we'll support a fledgling service in relationship to this. So evaluating how we're getting on in relationship to effect on one hand and any harms on the other. Really important harms. We're not looking at harms in research. We haven't found lots of harms in our research, which is really positive because it's made people go, okay, well, this isn't harmful, we're going to do it, because it's a way of augmenting something that's already out there. So we have now got a clinical provision within the NHS, and I just wanted to talk about the early challenges of that and the creation of XR Therapeutics. So we received 30 referrals. They all needed individual funding requests, most of which weren't then supported. Pathways needed to agree those with commissioners. There was a need for the technology, of course. There was a need for setup and training. The costs suggested were prohibitive. But then we received some funding from Innovate in relationship to iCure, and we were able to take forward an evaluation internationally of whether this was a good idea to pursue or not. And universally, whether it was in the Far East, or the Middle East, or in North America, or Europe, everyone said this is a great idea, you should do it, and therefore that's why we then took the decision at Newcastle University to create a spin-out company. We went through a process in relationship to that. So this is a spin-out company that is co-owned by Newcastle University and the NHS and a variety of other people who very might prefer to talk about. I'm going to end by talking about the real challenge for being a clinical academic working in this sort of area, and the balance between academic roles and industry roles. So, you know, I've gained whole loads of new skills and challenges. I've never worked in the private sector. I've worked in the public sector all my life. I'm not a businessman. We've given away our IP at Newcastle University to the company. I relinquished control because the chief executive has control. I sit on the board, and that has an element of leadership there, but I'm not in charge. And therefore I'm influencing policy in relationship to what happens in the NHS and what we think is important in relationship to effect, evaluation, safety, and so on and so on. And I would end by saying it's really important for those of us who spin companies out to remember it's really not about money. That's not what we have gone into this for. We didn't start this in 2010 with that in mind. For us, it's about getting this intervention out there, and there's no doubt that XR Therapeutics is a vehicle to getting something out there that otherwise won't see the light of day. A few thank yous to me from the people who've taken part in research. I'm here today. There's a whole team of people who've worked on this over the years, and happy to speak if you'd like to come and find me later. Or answer questions as we go forward, or hear from you another way, and then hand over to Billy. Thank you.
Hi everyone, delighted to be here. Haven't got the same roots as Jeremy has, so I can't say I'm from Manchester, but there is links to Manchester, which I'll talk about in a bit. Before I go into what we've done as a company, so what we've done with the research, I want to play you a video to give it a bit of context. So the video will show you what we currently do and a little bit of the roadmap of the products that we've got coming out very soon. I'll touch on some of the other products that you saw there, but one of the main things I want to start off with is, obviously Jeremy's talked what happened in research and working with autistic patients. So what we knew, I suppose, starting the company is that if this is going to be applicable to neurotypical patients as well. So we reached out to NHS trusts, and 2 IAPT or talk therapies departments took it on board. Said actually we're going to think this is really useful, and we think this will work for our waiting lists for step 2 and step 3 patients. So we're actively treating patients now in both of these trusts. They're coming into our studio and delivering therapy, and I'll touch on about the other things that they're moving on to soon as well. But that's really exciting for us because we're getting real world data, instant feedback from therapists. We've managed to adapt and iterate the technology more and more week on week with all of that great feedback and insight. Our CTO Sean's at the back of the room, and he hates me for this because I'm always saying, oh, we can do this and we can do that. The great thing is it works now. but we strive for perfection. So I always say there's, you know, if you've got a software package and you suddenly open it and you see lots of updates and you go, oh wow, that looks so much better. That's what we're doing in the background at the moment with it, but its core works and works really, really well. We've also sort of broadened out and talking more in depth about what we treat. So we're looking at mainly all of the anxiety disorders. That's where we sit within these services. So you know, general anxiety disorder, OCD, social anxiety, health anxiety. What's great about the technology and what we do is, especially in the early stages, people used to come up to us and say, can you make this? The answer is always yes. We can build anything, but the great news is now we've got such a depth of scenes and depths of what you can do in there. That iteration in new scenes is becoming less and less, because what we're doing is we're creating in these environments everywhere as a therapist you could take the patient to. It's very rare that you would use every single functionality in every single scene, but as a therapist you've got them there. So knowing what's happening with that patient and where you can take them to. And the real world data is showing this at the moment. So 95% of all patients showing noticeable improvement, with 71% showing either completely recovered or signs of major improvement. And we're gathering this real world data every week at the moment, which is fantastic. We haven't forgot about autistic people and people with learning disabilities. So NHS England funded us about 8 months ago to adapt our materials for people with learning disabilities. We've done that successfully, and as part of that, I love this case study, we treated a patient with learning disabilities and autism who had a dog phobia, and so bad that he was struggling to leave the home. He now has a dog, which is one of my favourite outcomes. So since then, SBRI, which is NHS England money, have given us a bigger fund to roll this out across the UK and create 4 new sites. Here's the Manchester one. We're in conversation with Manchester about having one of the sites here, and that would be fantastic if it comes off. We just agreed recently with Sheffield, that Jeremy, you didn't even know that, but Sheffield come on board. Because we want to spread across England as well, and that will be available to treat autistic patients, people with learning disorders or both, but also there'll be provision to treat other patients in there while that system's there. So it's a real good opportunity out from Manchester. So on the video you might notice that at the end, remote delivery, where you could see 2 pictures of 2 people in there. So this is just about to go live. So the 2 trusts that we're working with are going to be starting to use this with their patients, probably in about 3 weeks' time. Now, the reason we did that was you saw our huge curved screen, which is like a mini IMAX cinema, which is fantastic, it has the wow factor. But as somebody mentioned before, equity of access, that isn't available for everybody, and people don't want to travel for treatment, and we've got one site in Gateshead, and how would that work? So we've developed it, so I say we have, and Sean himself over there has. We've developed it so it's available on laptops, tablets, phones. So therapists can be based anywhere. They share screen, they're in the same scenario together. The therapist has complete control of it. The patient doesn't see any of those controls, and they're taking them through that at their pace. But as the talk therapies department said to me last week, that's a bit of a game changer for us, because the majority of our therapists deliver most of their treatment remotely. So really excited about that. The metaverse delivery, which you saw a bit of, avatars appearing there, so that's still in the background being worked on at the moment. And we're just getting some money from Innovate UK to look at incorporating AI tools, but specifically in development of scenes. So we're not at the point of giving an AI therapist in there, because that's not what we want to do. What we want to do is enhance therapists by giving them this. This is not to replace it. We're not in there to deliver the treatment ourselves. We just want to enhance therapists. So this is on the remote delivery, so I'm just going to play this video to give you a little bit more context. you can see at the bottom of the screen all the controls that are coming up. So this is a healthcare centre, it's an MRI scanner. You would never go this fast for a treatment. We see that the therapist is controlling where they go in the scene, and eventually into an MRI scanner, and then eventually on it and into it. So basically how that works is all of those scenes are available in the back end of our website for therapists. They pick what they want to do with the patient, they send that out and then they both appear in the same space together. But that's really, really exciting. And that's everything. I suppose the only other thing I'd like to say, I was lucky enough yesterday to witness another session. And this was a step 3 patient, quite complex. The therapist was brilliant, which we told her afterwards because we were allowed to observe the session. And this was a patient who had a real chronic fear of heights. So we've got several height scenes. So as we have with everything, we've got a high-rise building where you move every floor onto the balcony, peer down. We've got a bridge where you can lean over. And the therapist actually stood with the patient in the environment and had them looking over the bridge. And hearing it was fantastic. When she came out, she said, this would have took 4 to 5 sessions if I'd been doing this in my normal method. I can't believe the speed at which he's improved in that, and I can't wait to get him in a week's time. But yeah, so that's us. So we're really excited. We're exhibiting today as well, so come and talk to us, and you can have a bit of play with the technology. And anybody who's interested in looking into this, embracing it, and want to know more, just come and have a conversation with us.